Assalamu alaikum. We will continue the subject of the adrenal gland. In the last lecture, we discussed the Cushing syndrome. Some of the important points to be known about the Cushing syndrome is that some preoperative management is needed in patients with Cushing syndrome. Patients with Cushing syndrome are more liable for infection, thromboembolism, and myocardial infarction, so that prophylactic anticoagulation antibiotics are essential preoperative management. Postoperatively, in a patient with Cushing syndrome who treated surgically following unilateral adrenalectomy, supplemental cortisol is needed in order to maintain the normal serum level of cortisol, because the contralateral kidney is almost always suppressed during the disease, and once we remove the adrenal gland, it will remain suppressed for a long time. During this period, we have to maintain a normal serum level of cortisol by administration of parenteral cortisone in a dose of 15 milligram per hour, followed by a daily dose of 100 milligram for 3 days. Then the dose should be gradually tapered. In a patient for bilateral adrenectomy, steroid is initiated as the same as the unilateral adrenectomy, but the steroid should be given for life. A patient with adrenocortical carcinoma, incidence, it is usually a rare tumor, account 1 to 2 cases per million population. Clinical presentation: 60% of those patients with adrenocortical carcinoma are associated with cortisol excess. They present with Cushing syndrome. The remaining patients with non-functioning tumors usually present with abdominal mass, abdominal discomfort, or back pain due to effect of the larger tumor. Diagnosis should be started with biochemical workup in order to exclude functioning tumor by estimation of dihydroepiandrosterons, cortisols, and catecholamine to exclude pheochromocytoma, and together with dexamethasone suppression test to exclude Cushing syndrome. Then MRI and CT scan are equally effective in managing adrenocortical carcinoma. Treatment by complete excision of the tumor, and it is associated with favorable survival and should be attempted in all cases. Congenital adrenal hyperplasia, or what we call it adrenogenital syndrome. There will be virilization and adrenal insufficiency in children which are pathognomonic of congenital adrenal hyperplasia. What is the congenital adrenal hyperplasia? It is an autosomal recessive disorders primarily due to the enzymatic defect in the synthetic pathway of cortisol and other steroid from the precursor cholesterol, so that there will be adrenal insufficiency in the synthesis of cortisol in the adrenal gland. The most frequent defect in about 95% of cases is the 21-hydroxylase deficiency, with an incidence of 1 per 5,000 live births. As a result of low cortisol, there will be excessive ACTH secretion caused by loss of cortisol secretion. This lead to an increase in the androgenic cortisol precursor and lead to congenital adrenal hyperplasia. Congenital adrenal hyperplasia usually present in girls at birth with ambiguous genitalia and late onset disease at puberty. The cause of excessive androgenic steroid is that there is a specific deficiency of cortisol line, while the other cortisol precursor, including the androgenic cortisol, is normal. Once the cortisol decreased, so the ACTH will stimulate the other androgenic hormone in the adrenal gland. These androgenic hormone result in virilization and appearance of male characteristics, so that the girl at puberty present with beard, excessive hair, and ambiguous genitalia. Adrenal insufficiency. Primary adrenal insufficiency is caused by loss of the adrenal function. Symptoms are only evident when more than 90% of the adrenal gland is destroyed or necrosed. It is either acute or chronic. Acute adrenal insufficiency usually present with shock, in addition to fever, nausea, vomiting, and abdominal pain, together with hypoglycemia and electrolyte disturbance. The condition Waterhouse-Friderichsen syndrome is associated with the meningococcal septicemia, is one type of adrenal necrosis, bilateral adrenal necrosis associated with adrenal insufficiency, and it is associated with high mortality unless early management is attempted. The other type of adrenal insufficiency is a chronic one, and the most of the times patient develop over many times over a long period of time, and patient present with anorexia, weakness, and nausea. The result of negative feedback mechanism, the ACTH and the melanocyte precursor hormone increase and cause hyperpigmentation of the skin, oral, and mucosa. And this is typically seen in a patient called Addison disease, which is an autoimmune disease that affects the adrenal gland, causing progressive destruction of the adrenal gland with the subsequent adrenal insufficiency. Hypotension, hyponatremia, hyperkalemia, and hypoglycemia are commonly observed due to loss of the mineralocorticoid activity of the adrenal gland. Diseases that associated with adrenal insufficiency include polyglandular autoimmune disease syndrome, including Addison disease, tuberculosis, following bilateral adrenalectomy, as we said, in treatment of Cushing syndrome, hemorrhage in the adrenal gland, bilateral adrenal gland hemorrhage, or hemorrhage elsewhere, result in severe hypotension with subsequent adrenal necrosis. Metastatic disease in the adrenal gland, systemic disease like Boykin disease, amyloidosis, and Wilson disease. Hereditary diseases include adrenoleukodystrophy, adrenogenital syndrome, as we described, and HIV infection. Disorder of the adrenal medulla and adrenal and neural crest derived tissue. The most important and the most common neuroendocrine disorders of the adrenal gland is the pheochromocytoma and paraganglioma. Pheochromocytoma is defined as tumors of the adrenal medulla and the sympathetic ganglion, which are derived from chromaffin cells, which produce catecholamine. So it is called pheochromocytoma because it originated from the chromaffin cells that produced adrenaline and noradrenaline. The prevalence of pheochromocytoma is greatly varied between population. It is usually range from 0.1 to 0.6% of population. And the pheochromocytoma is the tumor or the disease called the disease of 10 or tumor of 10 because or 10% tumor of 10%. because 10% of them is inherited and 10% is extra-adrenal, 10% are malignant, 10% are bilateral, and 10% occur in children. So it is called tumor of 10%. For that reason, we call it 10% tumor, because it occurs 10% in children, 10% extra-adrenal, 10% bilateral, 10% malignant, and so on. The 10% of them are hereditary, and the hereditary causes of pheochromocytoma that are an association with this disease are the multiple endocrine neoplasia, or type 2 or MEN 2 syndrome, familial paraganglioma syndrome, von Hippel-Lindau syndrome or disease, and neurofibromatosis type 1. Pathologically, the pheochromocytoma looks like a tumor with grayish pink color, and it is highly vascularized tumor. It's highly vascular tumor with larger tumor area of necrosis and hemorrhage may be noted. Clinical features of pheochromocytoma are primarily due to catecholamine excess or secretion by the tumor and are typically intermittent. In total, about 90% of patients present with a combination of headache, palpitation, sweating, and hypertension are more likely to have pheochromocytoma. So that the signs and symptoms of pheochromocytoma can be summarized as the following: hypertension, which is either paroxysmal or continuous, headache, sweating, palpitation, pallor, weight loss, hyperglycemia, nausea, and some psychological disturbances. Diagnosis. First of all, we have to diagnose the biochemical status of the patient in patient with pheochromocytoma by elevated adrenaline and noradrenaline precursors by estimation of 24-hour or 12-hour urine collection. We can estimate the metanephrine and normetanephrine, which are precursor final product of the epinephrine and norepinephrine, together with determination of a free plasma metanephrine and normetanephrine. After biochemical diagnosis, in these cases, in biochemical diagnosis, the level of this end product of these hormones will be elevated to up to 40 times above the normal range. After biochemical diagnosis, we have to have a radiological imaging in order to localize and to characterize the tumor in the adrenal gland. It is preferable to do MRI over CT scan, because CT scan and its associated contrast medium might evoke an increase or shooting of the blood pressure. So MRI is the best modality for identification or characterization of the tumor. Other radiological imaging are the MAGPI or meta-iodobenzyl guanine scan. Single photon emission computed tomography is also beneficial, and it will identify 90% of primary tumors, and it is essential to detect multiple or extra-adrenal tumor and metastasis associated with the malignant type of pheochromocytoma. PET scan or positron emission tomography is another modality of imaging modality in the management of pheochromocytoma. Treatment. The classical treatment is by laparoscopic resection of the adrenal gland, but if the tumor is large, more than 8 to 10 centimeter, or the radiological features showed that the tumor may be malignant, at that time open method of resection is preferable. Some important point we have to know about the pheochromocytoma. As we said, the pheochromocytoma associated with the increase in the level of the catecholamine. So the patient, they have very high and severe increase in the blood pressure. This blood pressure and symptoms of increase of catecholamine excess should be controlled preoperatively by administration of the alpha blocking agent, namely phenoxybenzamine, to block the catecholamine excess and its consequence during surgery, to control the blood pressure shooting, which is usually occur. This shooting usually occur at the time of induction of anesthesia, during the tumor manipulation and after tumor removal. So we have to control these symptoms of blood pressure shooting during surgery by preoperative control of these symptoms by administration of the alpha blocking agent. An additional beta blocking agent is required to control tachycardia and arrhythmia, but we should start beta blocker only after the patient is completely alpha blocked by the alpha blocker agent. The other tumors is the neuroblastoma, which arise from the sympathetic chain. Definition: neuroblastoma is the malignant tumor that is derived from the sympathetic nervous system in the adrenal medulla or the sympathetic chain along the paravertebral side. It may occur in the adrenal gland or the abdomen, chest, and rarely in the neck and pelvis. Pathologically, the tumor usually encapsulated, usually pale and gray surface. It may show hemorrhage and necrosis in larger tumors. Clinical features: it is the tumor usually predominantly present in children less than 5 years of age. Symptoms of the tumor are usually due to tumor growth or by bony metastasis, and patients present with a mass in the abdomen, neck, or the chest, proptosis, bone pain, or sign and symptoms of metastasis anywhere, and it occurs in 70% of cases at the time of presentation. Diagnosis: biochemical evaluation by estimation of 24-hour urinary excretion of vinyl mandelic and homovanillic acid, dopamine, and noradrenaline, which might be associated with the tumors. Increased levels are present in about 80% of those patients and require some preoperative manipulation. Accurate staging requires CT scan, MRI of the chest and the abdomen, together with bone scan to exclude bony metastasis. Treatment: prognosis usually depend upon the age of the patient and the stage of the tumor. Treatment option include surgical excision and chemotherapy, and most of the times a combination of both. Thank you very much.